everyone. Greetings to my esteemed panelists and to you as well. Thank you so much for having us on here, and I'm looking forward to the conversation. I think to answer that question, I'd have to start with how we build Sila Health, which is, having to take into consideration insights from the ground, knowing that, Africa has the fastest growing internet adoption, internet penetration by comparison is growing at a faster rate than anywhere else in the world, which meant that if we were to create something that was going to scale across the continent, it had to be something that harnesses the internet. And we also knew that the region also suffers from an unnecessarily high cost of internet, with an average of about just over $6 per gigabyte. Sub-Saharan Africa has the highest price for mobile data. So we also knew that what we were building had to be something that was available on low-cost platforms, platforms that didn't take up too much bandwidth, that were accessible to people across the economic spectrum. And also looking at what it meant to build something within the e-health space that connected patients to doctors. We were also cognizant of the fact that doctor-patient ratios on the continent are on average one doctor for every 5,000 people. So what that means then is that we can't connect the same finite amount of doctors to a growing population. And we had to make use of scalable technology like machine learning to reach patients at scale. And what we built was a machine learning model that handles low-level interactions with potential patients. And what it essentially does is glean information around symptoms that they might be presenting, and also through a formulaic approach, present a prognosis on the basis of the likelihood of someone suffering from a disease, specifically looking at the prevalence of these diseases in Africa by age group, by gender, and also by looking at risk factors like lifestyle indicators that include, whether or not someone drinks or smokes and all these other things. And we launched in 8 countries initially because we launched as a fully autonomous platform. So we were not connecting patients to doctors directly. We were working solely with the intention of allowing people to have their low-level questions regarding their health answered instantly on platforms like WhatsApp and SMS and Facebook Messenger. Because for a lot of these people, the luxury of going onto websites like WebMD to get a general question regarding your health, something that's not life-threatening, is something that they can't afford to based on the cost of the internet. And for a lot of people, accessing the internet is essentially accessing WhatsApp and Facebook. We had to, in making considerations for localizing this in the different countries, we built a separate machine learning model that handled small talk. And there's a Financial Times article that documents this. But the idea there was, how can we invest in localizing the solution to, in some way ensure applicability and appeal in every locale we're focused on. And we also knew that every place is different, and what might be like social quirks to someone who is not from an area can essentially make or break a solution whose success relies on the fidelity of its conversational interface. And looking at how we have approached, how we can enable people to access quality consultations, and as you asked as well, even if these are cross-border consultations, the first thing that we wanted to answer is, how can we use digital tools to bring transparency across the value chain and ensure a level of accountability at every single touch point? So when someone books an appointment with a doctor, how do we ensure that the sponsor can attest to the quality of care that they've paid for? How do we ensure that the outcomes for the patients are as high as they can be? How can we leverage, predictive modeling, for example, to look at who might drop off from drug adherence, for example, and how can we use the ecosystem of tools and products we've built to improve quality of care, as well as improve service delivery for the providers on our platform. And we did a really good job at achieving this, but now looking at how we can apply this across multiple territories, I would say, you know, as an entrepreneur who's of course not well versed in the regulatory landscape and policy formation and implementation, you know, speaking almost vernacular, I think regulations that encourage innovation instead of stifling it are what we need in order to enable people to access quality consultations and spread this wealth of talent in the medical space, to allow people who are in places that don't have that much resource in terms of ability to connect people to basic healthcare to be able to access it. When we look at data privacy and the legal implications of providing care across jurisdictions, I think as you know, a technology forward company, we've been having to self-regulate in order to ensure that while we are moving at the speed of the problems we are finding, we are doing so in a way that should we be regulated in future, we wouldn't have to pivot too much in terms of our model and our operational, I guess, standpoint. And I also think we need, you know, region-wide conventions on how to administer care and how data privacy policies factor in cloud-based storage and enforceable encryption protocols. Because I feel like as a continent, we're still lagging behind in what it means to, you know, ensure privacy at a certain level, what it means to share data, while completely ignoring what it means to administer care virtually, what it means to be, you know, physically in a practice where, you know, doctors can now, in a sense, you know, conduct consultations from, you know, the privacy of their homes and doing so with patients in their homes. So what does it mean then to store data securely and privately when you know, the rest of the world has been using cloud-based storage and encryption protocols? So I think there's still a way to go. I can speak confidently on what the situation is on the ground in Zimbabwe, which is where we predominantly operate. And I'm sure it might be different in other countries, but I'll just put a pin in that for now. Continue the conversation.
Yes, I can't agree more with you. In this space, that's one of the headache. So in our case, we are at a very interesting phase with our product. We've after having gone through 3 functionality tests in the UK, we're carrying out demonstrations in Nigeria, and now about to kick off the procedures. Just like the as rightly said, it takes about there is a concession actually for COVID. They say it takes about 2 weeks to get an approval. But like you said, we actually in our own timeline, we have 2 months, you know, in that space, rather than just saying, oh, well, the concession says 2 weeks and it's going to be 2 weeks. It's never going to be 2 weeks. We understand that. And those are some of the gaps in the system. And a lot of things can really happen if we just execute. When we went to some of the ministries and we engaged them, there is documentation, there is procedures, there's everything in place, but the tools to make those things happen do not exist and will not exist. Hence, it will floor the whole process. I mean, detailed documentations as to how a clinical process trial should be carried out, it's all there, but in terms of executing it, doesn't happen. So it somewhat brings to the thought that maybe this part of the procedure was funded itself, was never the fund to get the work done. So there are gaps in our system, and that's why I was saying earlier that we should be patient. And you know, Dr. Taka was able to shed more light to that as to the 4-year time that's required for things to get harmonized. It's very, very important. In our case, talking about data, given that we're dealing with respiratory care, one of the things we always measure is the oxygen saturation of the patient, right? To ensure that, well, you know, is the patient getting any better, or should we, you know, change medical care options, or, you know, whatever we should do. And that data is the data of the patient. It's not our data, right? So the core of the data is the data of the patient, but then we take a snapshot of that data to make room for doctors to share and learn. And okay, well, I've had this patient and this is how they're improving, this is how they're deteriorating, and you can actually see that graph, but it's not, useful beyond a pictorial image, which the patient actually, well, not really approve of, because it doesn't link back to them as a person. It's the raw data is their data, but it doesn't link back to them. But you could say, okay, well, I was dealing with patients ABC. It doesn't even need to mention the name, but for learning purposes, to have a cohesive environment whereby doctors across the markets could learn. We've had that in place, and it's quite useful.